Welcome to another episode of the MEGIN Spotlight series. Today we are delighted to have Professor Hanna Renvall as our guest. Professor Renvall is the head of the MEG Lab at BioMag Laboratory at Helsinki University Hospital. Hi Hanna, thank you for joining us today.
Thank you for inviting me.
So we'll start off with the first question today. Can you tell us more about the MEG Lab at BioMag Lab? How is MEG incorporated in clinical and research work in this institution?
Well, our laboratory is operated in the Helsinki University Hospital. So clinical diagnostics and clinical research quite naturally form the core of what we do. We basically serve the whole Finland and also some other countries like Norway in the established use of MEG in clinical diagnostics. MEG has a very strong role in the pre-surgical evaluation of refractory epilepsy. At the moment in our laboratory, we evaluate like 1 to 2 epilepsy patients per week. It may not sound a lot, but we are in the end a fairly small country. And to my understanding, Finland is currently the most active country in using MEG in this field, in the whole world, I mean. So surgical treatment for epilepsy has been proven to be very effective, and most likely its role will increase in the future worldwide. So that means that also MEG's role in this field will increase. In addition to epilepsy, we do research in the fields of other potential clinical applications of MEG in our laboratory. And recently we have especially been interested in mild traumatic brain injury and different degenerative neurological disorders.
That's great, thank you. Thanks very much. So we think our audience will also be really interested in the AI Mind project you're involved in. We've had a chat about this before, and can you tell us a little bit about the aims of the study and how many participants are you and all other research sites are hoping to assess?
Yes, AI Mind is a European Union supported research project. It aims at finding people who are in risk of developing clinical dementia in the near future, especially Alzheimer's disease. As we all know, dementing disorders are very common, and they have huge effects both at the societal and at the individual level. Their role is likely to increase even more as the life expectancy is increasing everywhere in the world. We are targeting in this study mild cognitive impairment subjects. So mild cognitive impairment, or MCI, refers to a stage between a normal aging and clinical dementia. We know that these people are in particular risk. 30 to 50% of these people develop into clinical dementia within the next 5 years. And at the moment, we do not really have good tools to pinpoint the subjects of this MCI population who are really at the highest risk. It would, however, be very, very important for the best possible follow-up of these patients and for providing interventions to the exactly right people. For example, several new medications are about to enter the field, and some of them already are available in the US. And these new drugs are not without side effects, and they are also very costly. So we should find the people who are most likely to benefit from them most, and as early as possible. In AI Mind, we are addressing subjects who suffer from MCI with electrophysiological, neuropsychological, and various blood and genetic biomarkers. So we have a huge collection of data from these subjects. And the aim is really to find those who have the most increased dementia risk. We will pool all this data into artificial intelligence analysis, so that's where the name AI Mind comes from. So the idea is to find the most informative tests and markers of all this huge collection of data we are collecting. At the moment, we are aiming at 1,000 participants, which is very big, biggest in this field ever collected in the world. So we have 4 clinical sites, Oslo, Rome, Madrid, and Helsinki. Each are targeting 250 subjects. So it's indeed a very interesting, also really heavy project, but we are very proud to be involved in it.
Yeah, that's really interesting. And as we understand it, BioMag Lab is the only site in the study that is actually incorporating MEG. So can you let us know a little bit about why MEG was selected as a method for the study, and how many times will a participant or a study participant receive an MEG scan, for example?
Well, the main idea of using EEG and MEG in AI-mind study is that we know that in Alzheimer's disease, the earliest changes in the brain take place already years, maybe even tens of years before the clinical symptoms appear, and they are most likely to take place at the neuronal connection level. That means at the level of synapses. So the idea is that for currently unknown reasons, the neural firing gets hyperexcited, and this results in accumulation of harmful amyloid bodies outside the neurons. And this kind of results in a vicious circle, which hyperexcites the neurons even more, and eventually the neural firing somewhat fades down. And MEG and EEG as electrophysiological methods may be thus the earliest methods to pick up this pathological hyperexcitability in the brains. And there is indeed good evidence for that already from earlier MEG studies, example by Professor Fernando Maestro's group in Madrid. Well, EEG is of course much more cheaper and more available around the world than MEG. And also in AI-Mind project, there is a lot of emphasis on developing EEG-based tools for these practical reasons. However, at this research-intensive stage, we know that the better spatial accuracy that is provided by MEG may be highly informative in pinpointing to the most informative things in the EEG signals as well. And to those of us who are using both EEG and MEG in practice, we can also value a lot the much smaller amount of artifacts and the easiness of using MEG in clinical practice, especially when we are measuring special subjects like in this study we are. Our original plan was to have MEG twice per subject during this project. So we are actually seeing this subject 4 times every 8 months. And the plan was to have MEG at 0 months and 24 months, and EEG at each of the 4 time points. But actually we have gotten a bit greedy, and we have been collecting MEG also at the mid-time points whenever possible, for comparing the signals between methods and also for their sensitivity in detecting the informative changes.
That was a great description of what's actually going on in the project with MEG, so I appreciate that. Thank you. How is MEG used in conjunction with other neuroimaging modalities offered in the AI-Mind project? How are you working to create multimodal images of the brain, for example?
So we are collecting MEG simultaneously with EEG, but honestly, I have to say that we have not fully decided yet how to bring these 2 signals together in the end. But along the project, we are also actually developing these multimodal techniques and also tools to bring data better together and make it more automatized. So for example, we are investigating here in AI-Mind how to use 3D scans of the EEG electrode locations in boosting source localization instead of using manual digitization, which we usually do in clinical practice. So for subject-specific head models, it's critical to have an accurate estimate also of the EEG electrode positions, and these kind of things we can kind of develop along the project as we collect so much data.
So I guess you must be doing some research already in the study. So are you able to share with us any preliminary insights from the research from using MEG as part of the study?
Well, we can at least already say that MEG would definitely be the method of choice for me and us in practice here in Helsinki, taking the challenges that are related to putting the 128-channel EEG cap that we are using in the project, which takes already 30 to 45 minutes, and the subjects are already quite tired after that, which is a real clinical challenge. But as to the data in itself, we have already started comparing MEG and EEG signals because we have the special opportunity to really now look at it in this patient population. And so far, as expected, the stability and replicability of certain signal features is clearly better with MEG. And this is also something we are really looking into, in which is really possible only with this uniquely large data set here.
So do you foresee MEG being incorporated into clinical applications for Alzheimer's and dementia in the future?
Yes, definitely. Actually, our colleagues in Amsterdam's memory center are already doing that. So they are already using MEG in some of their patients in aiding the clinical diagnostic path. But globally, the use of MEG is still very limited for this target population. And especially for finding the first signs of the developing disease. For that, we still need to do research like we are doing now in AI-Mind. But I think these kind of projects can bring us that information and help us also asking the right questions from the MEG signals and at exactly the right time of the disease course.
So in addition to your work on the AI-Mind project, you've also recently been one of the authors of a research study on MEG combined with machine learning to classify mild traumatic brain injuries. We'd really like to learn a little bit more about this. So how are you designed the study and what are the findings?
Yes, mild traumatic brain injuries have been another very promising clinical application for MEG in the recent years. So many groups have been working on that, and so have we. As you probably know, traumatic brain injuries are very common. Approximately 70% of them are considered mild. The prognosis of these mild traumatic brain injuries is generally very good. So most patients recover very well within a few months. However, we know that 10 to 15% of these patients do suffer from prolonged symptoms, typically fatigue, problems in attention and memory, and these may last for months and be quite problematic for the patients. They are often young and they don't necessarily even seek medical attention in the acute phase. And even if they do, the risk for these prolonged problems may go unnoticed. In these very mild ones, the structural brain scans taken with MRI or CT are very often negative, so we do not get objective signs of the trauma with them. And others have been now using MEG for finding early functional signs of neural level disturbances in order to find those patients who may need extra follow-up and, for example, neuropsychological support for coping with the symptoms. And indeed, our earlier studies using conventional kind of eyeballing analysis showed that in around 30% of mild traumatic brain injury patients, we can detect excessive slow wave activity early in the phase of the disease, but then it goes away as we follow up these patients for months. And similar kind of slow wave activity is not seen in age-matched control subjects. What we have now recently been doing, we have been looking at the same data with machine learning analysis with the idea that whether it could make it more sensitive. And indeed, our recent publication showed that the same data for which the eyeballing analysis showed 30% of accuracy in finding the mild traumatic brain injury patients, the machine learning algorithms were able to find with the median accuracy of 80 to 95% the patients. So this is quite a promising and quite automatic analysis, so that might be quite easy to take to the clinical practice. And importantly, we also replicated the findings in another independent data cohort here in Finland, showing that the results are quite robust.
Thank you. That's really interesting, I think. We also know that you have been or are very involved in MEG Nord, a meeting for Northern European and Nordic countries to develop MEG research technology and clinical applications. Can you let us know a little bit more about this meeting and why it's something that you dedicate time to and so they can consider it for future years? So, you know, our audience might be interested to join, I guess.
Yes, MEG Nord is a great meeting. So we organize it every year at one of the Northern European MEG sites, and it has become really popular. So this year we had it in Helsinki, and we had around 150 participants, which is quite a lot taking the size of the community. And I think the idea for this meeting came first from Sweden by Daniel Lundqvist. At least they were the first ones to organize this meeting around 10 years ago. And the idea is to focus on the collaboration between the different MEG sites in the north So we exchanged results, ideas, and recently also people. So we got some funding from Nordforsk Foundation for traveling grants. And for example, just yesterday, one of my PhD students went to Stockholm to do research for a month. So we are very open to visitors from outside Northern Europe as well. So we sometimes have had them. So please follow us at the MEG Nord website and join.
That's great. Thank you. So thank you. We've come to the end of our interview, and thank you so much for making time for us today, Hanna. This has been a very informative interview, and I'm sure for our audience very interesting too. And hopefully we'll have lots of people join MEG Nord next year. So thank you very much.
Thank you.